My name is Aliza Ben-Zacharia, and I am a nurse practitioner. I have my own MS practice independently, and I am an assistant professor at Hunter College, Bellevue School of Nursing in New York City, and the co-director of the Research in EBP QI Fellowship at the Mount Sinai Phillips School of Nursing. The presentation today, the title of the presentation today is Acute and Chronic Management of Multiple Sclerosis. It's a packed presentation, lots of information about early treatment in MS, the DMT, disease-modifying treatment, symptomatic care, rehabilitation. So there's some areas that I will go quickly. If you have any questions, you can always email me at abz241@nyu.edu or either through the CMSE or IOMSN. So the agenda, as I mentioned, I will do an introduction, early treatment, acute relapse management, the disease-modifying treatments at MS, symptomatic care. I will conclude with some principles of shared decision-making since it's close to my heart, and I'll conclude the presentation. You can always stop in the middle. This is, again, because we have so many disease-modifying therapies, it's a long presentation. So the objective of the program is to describe the acute management of MS relapses, identify disease-modifying treatment for MS, for the different phenotype of MS, relapse and remitting, secondary progressive, primary progressive, and then thinking about active disease versus inactive disease. And lastly, I will discuss symptomatic care of MS, including Payne's principle of shared decision-making. So when we think about the MS disease itself, is to treat and manage the relapses, to modify and change the course of the disease, minimize the occurrence of relapses, thinking about the clinical activity, which means relapses and disability, accumulation of disability over time, and we usually measure it by the EDSS, Expanded Disability Status Scales, that was developed by Kertsky, and then manage the symptoms and promote rehabilitation while improving quality of care, quality of life. So in introduction, I'm sure you all know MS is an autoimmune disease. It's a chronic illness. It's inflammatory, it's demyelinating, and neurodegenerative disease. It affects the myelin and the axon. We do not have any cure for MS at this point. We do not know what's the primary cause of MS at this point. However, we have multiple disease-modifying treatment to halt the progression of the disease, minimize relapses, and minimize accumulation of disability. There is extensive research about the etiology associated with MS, pathophysiology of MS, and of course, treatment of MS, and hopefully cure at some point. So early treatment is a principle that's very critical in MS because once you have damage, you cannot reverse it. You may treat it with some medication, as we'll discuss in a few seconds. However, you cannot reverse the damage. So prevention is the most important and critical principle of care in multiple sclerosis, which is a disease that affects the central nervous system, the brain, and the spinal cord, leading to multiple signs and symptoms, thinking, going to the bathroom, sexuality, feelings, sensory touch, weakness, balance, coordinations. Everything we do and think and feel is based on message and transmission from the central nervous system. I would not touch at all about pediatric MS. The principle of care is more about adult. I am an adult nurse practitioner, an acute nurse practitioner, not a pediatric NP or not a pediatric nurse. However, the majority of people affected by MS and the pediatric populations are teenagers, and teenagers are sometimes, they're like adults. Perhaps they don't behave like adults. Sometimes adults don't behave like adults. Anyhow, so let's continue the importance of early treatment. So as I mentioned, MS is an active CNS disease. Even if you do not have any clinical signs or symptoms of the disease, many patients you'll see outside in the street, and you won't even know that they have multiple sclerosis. Lesions occur early and are associated with irreversible damage. Dr. Lublin, Fred Lublin, my colleague at Mount Sinai, has shown that every relapse lead to some progression of disability on the EDSS scale. So even though some patient will feel okay after early relapse and think they recover, there are always some residuals of disability after each relapse. So the goal is also to minimize relapses and minimize progression of disability. Degenerative changes can occur in normal appearing white matter. So what's we think normal is actually abnormal. I think it's a very interesting and humoring factor and principle. However, we know today that there's some white matter that looks to our eyes because we don't have major tests that can tell us what really happened in the CNS. We use MRI, we use conventional MRI, some higher level techniques. However, we know today that there are some areas in the central nervous system, in the white matters, that appear normal, but they're not normal. There are some degenerative change. Damage can, of course, lead to permanent disability, to signs and symptoms, to effect on people's functions, independence, and quality of life. So therefore, early treatment, slows the accumulation of damage and disability and minimize the impact of the illness on individuals with MS. The relapse risks depend mostly on a few factors: younger age, female gender, more likely to have relapses, shorter duration of disease, ethnicity, specifically non-Caucasian. So those factors can increase the risks of relapses. As I mentioned earlier, relapse can occur in any location of your central nervous system, in the brain, in the spinal cord, and be identified and characterized by sensory symptoms such as tingling, numbness, paresthesia, motor disability or dysfunction, weakness, fatigue, impaired balance and coordination, vertigo, blurred or double vision, loss of vision, bladder and bowel dysfunction, sexuality impairment. So the list go on and on. And these new symptoms correlate with a new relapse in the absence of infections. Always important to differentiate between a true relapse and a pseudo relapse. So a true relapse means that the symptoms usually develop over a few hours and day. Then you have a plateau. The symptoms stay the same. There's not much change. And then recovery starts slowly a few days later. And that can last from weeks to months, the recovery and the hopefully come back to baseline. It's not always all the way to baseline, as I mentioned, based on Dr. Fred Lublin's study. Usually it's associated with new enhancing active lesion on the MRI. And there, when you suspect a relapse, you might consider to include gadolinium when doing the MRI. Although today we're very cautious with MRI using contrast gadolinium because of the accumulation of the contrast in your body. It's not completely eliminated after the MRI, and therefore we have to think, but in the occasion of a new relapse, new signs and symptoms, you need to look for activity. High dose corticosteroids, which we'll talk in a second, usually impact the quickness, the rapidness that the symptoms recover. It does not do anything to the underlying disease. And that's important. There is no evidence that IV steroids, corticosteroids, will change the underlying progression of the disease. The only thing that they do, they provide more rapid improvement once you have a relapse. Pseudo relapse, on the contrary, is an abrupt loss of function or sudden neurological deficits. It's usually more common with people with longer duration of disease. It's not associated with new enhancing or active lesions on MRI. Definitely, you do not need to use any treatment, and potential triggers usually for pseudo relapse are increased body temperature, increased effort, often infection, traumatic event, surgery, and psychological stress. Management of relapses. First, you want to differentiate. It's important, as I mentioned, to distinguish between pseudo-relapse and a true relapse. You look at the symptomatology, the evolution, the onset of the new relapse, the factors that are involved. You want to always rule out an infection and make sure you're dealing with a true relapse. You evaluate the severity of the relapse. Not every relapse requires treatment, requires steroids. As we mentioned, steroids help only to quicken the recovery, not doing anything to the underlying disease. So the impact on function, if patients are unable to do certain activity and an impact that overall function, it's important to treat, looking at the patient perception and continued worsening of symptoms and sign of the disease. So once you look at the severity and discuss it with your patients, always think about involving patients in the care, including discussion about relapse management. So once you decide it's a true relapse, once you decide that a treatment is required, you want to treat with IV, usually IV methylprednisolone, or either as opposed to the oral high dose prednisone, which is 1250. You take 25 pills a day of equivalence of 50 milligram each pill. Usually it's very surprising to me always. Patients tolerate it very well. They divide it throughout the day, but patients usually tolerate it. There is also the Actar gel that's given via injections that can also help. Usually it's used in those patients that oral or IV methylprednisolone, corticosteroids is contraindicated for them. So then you use the adrenocorticotropic hormone. Not always you use corticosteroids, taper after you give the 3 to 5 days intravenous steroids or 3 to 5 days oral IV dose prednisone. Sometimes you do the taper. It's dependent on the presentation individually of every patient. And then, of course, in those refractory relapses, the patient have not recovered after 7 days of high-dose steroids, corticosteroids, you may consider plasma exchange and plasmapheresis. There is some data to support the use of plasma exchange within 60 days of the relapse. As any other medication, corticosteroids have multiple signs and symptoms. Although you give it for a short period of time, about 3 to 5 and maximum 7 days, it may lead to hyperglycemia, hypokalemia, banana is usually good, hypertension, GI intolerance, thrombocytopenia in rare cases, leukocytosis, some psychiatric manifestation I've seen in some of my patients, psychosis as a result of use of corticosteroids. Over time, long term, it can lead to cataract or retinal necrosis and glaucoma. Bone, of course, the effect on bone and bone demineralization. So you need to really look at the pros and the cons of treatment. Skin, acne, impaired wound healing, and hypersensitivity. And also you may have avascular necrosis of large joints like the hip, sorry. Of course, as any other entity in medical care or nursing care, the non-pharmacological relapse management is important. So referral to rehabilitation is paramount, depending on the signs and symptoms as appeared with this new onset relapse. If someone has weakness or spasticity, you want to refer them to physical therapy and occupational therapy for fatigue management. Speech, if someone has swallow issues, cognition issues, social work and coping with stress, resources, finance, and many things that are associated with relapse or with the disease itself, with MS. And then use of community-based resources, home support, home care, and equipment as needed. So of course, when we think about disease-modifying therapy, I think as nurses and physicians, as experts in MS, it's important to know, and it's important to think about the fact that adherence is the most important idea here, because if patients are prescribed the medication and they do not take it, then there is no use for the prescription. So it's important to make that decision to start the medication, initiate the DMT, and stay on it. So it's the adherence and persistence of patients and individual with MS to the regimen of medications. I created this table. Hopefully I didn't forget anything. However, these are disease-modifying treatment timelines, and you can see from the 1990s all the way to the futures. So initially, we have mainly interferon and glatiramer acetates, different type of interferon, and Copaxone, which was the GA product. Then along the 2000, natalizumab, Tysabri, brand name, interferon sub-Q beta-1A, it's a Rebif, came in from, it was approved in Europe for a few years and then entered the market in the United States. And then Novantran or Midozantrons, the brand name, which is not used anymore due to cardiotoxicity and malignancy and leukemia. Then in the 2010, fingolimod, Gilenya was the first oral medication that was approved by the FDA for MS. Then long after, not too long after, teriflunomide, Aubagio, dimethyl fumarate, Tecfidera, and then alemtuzumab, Lemtrada, which is an IV. Along the 2050, generic glatiramers were developed. There are a few available today and on the market. Then interferon beta-1A, Plegridy, ocrelizumab, Ocrevus, cladribine, Mavenclad, and siponimod Mayzant, which is also an S1P, similarly to Gilenya. Then in the 2020s, ofatumumab, brand names Kesimpta, diroximel, fumarate, Vumerity, ozanimod, Zeposia, ponesimod, Ponvory, monomethyl fumarate, which is Bafiertam. And then future, we always need to think about the future in MS. I think everyone is excited about the Bruton tyrosine kinase inhibitors, BTK, and there are a few of them by different companies, evobrutinib, fenebrutinib, tolebrutinib, and masitinib. And then we have another anti-CD20, which is obinutuzumab. So as you can see, multiple medication, mostly effective in a relapsing form of disease. So it includes CIS, RRMS, relapse and remitting multiple sclerosis, and active secondary progressive multiple sclerosis. This is, I just put this just to understand the scope of target of this immune modifying treatments in MS and many other autoimmune disease. You try to target different places in the immune system to provide a halt to the disease and minimize the progression of the illness and minimize the occurrence of relapses. So you can see you have more non-selective autoimmune products, but you also have some selective. But even those that are selective, for example, natalizumab, which is against an adhesion molecule, we do have some side effects. So anywhere you interrupt in the immune system, you create sometimes the chain reactions that leads to some AEs and some interruption in the protective mechanism of the immune system. And the main issues or problem, if you may as well call them, are infections and malignancy. This is a table of all the disease-modifying therapy. Most of them appear here, not all, but you can look at their dosing and the frequency, which is often important for patients and caregiver. These are non-comparative relapse rates, just showing you a glimpse snapshot of the efficacy of different medications. So you can see the interferon and glatiramer on the lower left side of the slides, 31%, so in the 30%. Interferon beta-1A IM, Q week, that's Avonex, 18%. Interferon beta-1A sub-Q TIW, which is Rebif, 32%. Natalizumab, very high efficacious drugs at 67%. Fingolimod, 55%. Teriflunomide in the 30s. And then the methylfumarate, Tecfidera, 44%. So it gives you some idea of the relapse rate reduction in many of these products, which again is critical in MS, because if you prevent and minimize relapse rate, you can control the accumulation and progression of disability. So you can see the highest efficacious here is natalizumab reduction by 67%. So this is talking about disability. The first slide showed about relapses, and you can see similarly, the natalizumab had the highest reduction in sustained disability. Most have some pretty good efficacy in reduction of sustained disability, which is important because disability accumulation affect function among patients with multiple sclerosis. So let's divide them. I did the vision based on my opinion, my idea. You may disagree with it, which is okay and natural. The low efficacy and safe treatment, I only included interferon and glatiramer. Teriflunomide, although it's about 31% reduction in relapses, although have a good disability data, I included it in the medium efficacy. So here we talk mainly about interferon 1A and 1B, and then glatiramer acetates in lower. So we talk about them as injectable, although we have some injectable now in the higher efficacy, like ofatumumab. So I think we need to think and define them more clearly and make sure we talk about the injectable that were available in the 1990s. So what is the mechanism of action of interferons beta? They inhibit the synthesis of inflammatory cytokines such as interferon gamma, tumor necrosis factor alpha, and other. It downregulates the expression of major histocompatibility complex class 2 molecules induced by interferon gamma. So that's an impact directly in the immune system. Reduces antigen presentation to T cells, and that will minimize the progression in the disease, inhibits T cell proliferation from the periphery into the central nervous system, and downregulates adhesion molecules and promotes blood-brain barrier integrity, which all these important for the control of the disease of MS. So there are few interferon, I mentioned few of them. So of course we have the beta-seron, which is a 1B, and Extavia, which given subcutaneously every other day. And then we have the beta 1A, like Avonex, IM, given once weekly, and of course the pegylated interferon beta 1A, which is given every 2 weeks. So you can see annual relapse rate, for example, with pegylated interferon, it's about 35.6 or 36%. High robust reduction in T2 or new enlarging T2 lesions, 67%, although we have medication that are beyond 90%. And also reduction in enhancing lesion, acute new lesions by 86%. Good data, and the 2 weeks dosing was the one that's adopted, not the 4 weeks. Some, of course, side effects and AE associated with interferon, some injection site reactions. We've seen it, I've seen it in many of my patients. Discomfort with the intramuscular injection, local infection may occur, definitely flu-like symptoms, feeling feverish, body aches, and sleep issues, and then laboratory abnormalities such as elevated LFTs, liver enzyme, thrombocytopenia. You can see some reduction in platelets counts, anemia, hemoglobin, hematocrit slower down, and leukopenia. Mood alterations, I think that was all debated, and there is some very controversial evidence, but it seems that lately in the last few years that has changed, and clinician feels that interferon do not majorly affect mood of those in MS, and it's pregnancy category C. Always can manage these side effects, injection site reaction. You can use the autoject, proper technique, of course, make sure you take it out and have it at room temperature before the injection. So there are a few techniques that you can do. You can, when you start, definitely dose escalations, evening dose, and then hopefully you can fall asleep. You may use antipyrectic agents such as Tylenol or ibuprofen, and you always want to monitor labs and control the normality of blood parameters. So if there is an abnormal LFTs, you have to discuss this with patients, share the concern, and make sure that you either manage the medication, the interferon beta, and see what you can either do. Some people skip a few doses and monitor. Sometimes you have to switch completely the medications. Let's talk about glatiramer acetates, which is the same group. And again, these two medications are good. There's some people that would like safe medication, and that's why DMTs require shared decision making. There are many patients that would like to have a safe medication. So the mechanism of action induces naive T cells to have mostly Th2 effect, anti-inflammatory effects. It's compete with myelin antigens binding to the human leukocyte antigen class 2 molecule. It does T cell receptor modulation, induction of energy in myelin reactive T cells, and results in the expansion of the pool of anti-inflammatory effects by the Th2 cells using some kind of bystander suppression mechanism of action. The side effects of glatiramers, similarly to interferon, have some injection site reaction, although a bit different, localized erythema and edema, pain, itching. Mainly one of the significant injection site reaction of Copaxone is the lipoatrophy, glatiramer acetate, lipoatrophy. So you can see indentation on the skin, some loss of tissue of the dermis in many patients after multiple injection. There is a phenomena that happened with glatiramer acetates. It's called immediate post-injection reaction. Immediately after the injection, within seconds, patient can have flushing of the face, chest pain, palpitation. They'll become very, very anxious with some shortness of breath and nausea. Important to support patient and explain the AE to patient to have them prepare. It's not common, but it happens enough in many of my patients in the past. So you need always to educate patient about the potential of this AEs. There is no toxicity that we know of, and now we have long-term data from both glatiramers and interferon, and this is the only medication that it's a pregnancy category. So some clinician may leave Copaxone during the pregnancy of patients. This is just showing the data. I wanted to show some efficacy data about each of the medications. So this related to interferon and Copaxone and glatiramer acetates, and there is the data about natalizumab since they both appear at the same time. So you can see statistically significance, most of them except for the GA study, but you can definitely see a reduction in relapse rate, the annual relapse rate, between placebo and the actual medication. The placebo is the gray bars, and the drug itself is the orange or brownish. And you can see that all of them show reduction between placebo and the actual drug. So that was about the low efficacy treatments. Now we talk about the medium efficacy disease modifying therapies for MS, and will include teriflunomide and fingolimod and all the other S1P modulators. So S1P receptor modulator include a few medication I will share with you in a minute. But the main mechanism of action of these oral agent is that it binds to S1P receptor on circulating lymphocytes, and when they do that, they do the binding, they sequester those thymocytes and lymphocytes in secondary organs like the lymph node, and reduces the circulating lymphocytes in your blood and along the system, the circulatory system. So once they do that, it results in internalization of the receptor and loss of responsiveness to the S1P gradients that drives the lymphocytes to leave the lymph node and go out in the circulation. So it definitely minimizes the count of lymphocytes, T cells, and B cells, both. So I wanted to share with you the difference between all the S1P receptor modulators. So you can see the expression S1P receptor 1 is expressed in all fingolimod, ozanimod, ponesimod, siponimod, and that impact on AV nodes, conduction, the heart, and epithelial cells. So it's pretty broad effect. The S1PR3, only fingolimod. The S1PR receptor 4 is fingolimod. fingolimod, and then 5, you can see a few, again, fingolimod, ozanimod, and siponimod through effects on the CNS and natural killer cells. So it's important to really think about what selectivity each product has and where is their main impact. And the brain definitely has the higher concentration of S1P receptors. Usually cellular levels of S1P are regulated by the balance between the synthesis of by sphingosine kinase and degradation by hydrolysis or cleavage, suggesting a clinical role within the CNS, the central nervous system. So really important. And these receptors are expressed on neurons, on oligodendrocytes, on astrocytes, and microglia. So you can see that they are presented on all the cells in the central nervous system. And that's an important point. Once you block and inhibit and compete with S1P receptors, it's affecting all cells in the central nervous system. Each of these 5 different S1P receptor subtypes is bound to specific G protein, and each of them activates different intracellular signaling cascades. So when you interrupt in one way, you perhaps have multiple effects throughout the systems. But the main effect here also that you have less circulating lymphocytes. So these are the 4 medication. I put the brand name in each one because I think sometimes we talk about the brain and forget the generic name. But for this presentation, fingolimod, ozanimod, ponesimod, siponimod. So if you think, I included mainly the fingolimod, which was the first S1P. Again, although it's expressed on most of the receptors and the others are more selective, most of them have some kind of pre-treatment surveillance. You have to do blood tests. You have to make sure the patient had vaccination, especially for VZV, EKG. You want to look at their cardiac functions. Important to do also a baseline ophthalmologic exam to assess for macular edema. Of course, if anyone has acute infections or active infection, they cannot start treatment until it's resolved. The medication, the S1P, are mostly contraindicated in patients with certain cardiovascular disorders and those that have a prolonged QT interval. Definitely, there's some medication also that are contraindicated, those that prolong QT interval, like SSRIs, that most of our patients has to manage their depression, methadone, and many, many others. Few antibiotics prolong QT intervals. So you have to be cautious and knowledgeable about these medications that may and prolonged QT interval that are contraindicated in patients on S1P medications. This is the data from the Freedom trial. You can see there are 2 dosages of Gilenya, fingolimod, and placebo. So you can see if you compare those 2 arms that has different dosing of fingolimod, there was a definitely reduced annualized relapse rate as compared to placebo. The one that's approved in market and used in patient is the 0.5 due to safety. This is another trial related to fingolimod, and it's called the Transform trial. So you can see that annualized relapse rate also lower as compared to Avonex. Here it was a comparator. It wasn't against placebo. So you can see the annualized relapse rate in those that took Avonex, interferon beta 1A, was 0.33, and those on 0.5 fingolimod, which is the dose that's approved for care in patient with MS, it's 0.16. The one was the 1.25 was a little different, but this was not even higher, was not really approved for use in the US. So safety, both trials showed some cardiovascular issues, but mainly the Freedom bradycardia and AV conduction block, macular edema, elevated liver enzyme, mild hypertension, and then the other showed some skin cancer, melanoma, and others. PML cases have been seen in patients on fingolimod, and that's important to think about when you discuss this treatment with patients. Of course, the rebound effect when discontinue medication is being discussed by most clinicians, and it's pretty concerning when especially you stop medication before pregnancy planning. So this is Mason. I showed Mason because you need to also look at genetic testing before starting the medication. But before that, these are, again, expressed on the surface of lymphocytes and regulate the aggression, the coming out of lymphocytes from the lymph node. And similarly to fingolimod, although, again, it's selective for the 1 and 5 S1P receptors. Pre-work is very similar to fingolimod, although, as I mentioned, you have to do a test for CYP2, C9 variants to determine the genotype. There is an FDA-approved test for detecting CYP2, C9 variants to direct the use of siponimod. So this is definitely a available test. Needed to change this, but this is something that available today to really check the genetic test for patient on that would like to start siponimod, especially patient with secondary progressive MS, and all the rest is fairly similar. Teriflunomide or Baggio. So the mechanism of action, immunomodulator, immunosuppressive, it's an inhibitor of a certain enzyme that's called the hydroorotate dehydrogenase. And this is an enzyme that's necessary to pyrimidine synthesis and essential in the production of DNA and RNA. So therefore, it inhibits rapidly dividing cells such as T and B cells. And its parent compound, which was approved for the treatment of rheumatoid arthritis, RA, is called leflunomide. This is a clinically efficacy of teriflunomide, include the Tower study, as you can see, a very large study, 1,100 patients, that 3 arms, placebo, 7 milligram and 14 milligrams. So 2 different dosages for teriflunomide against placebo. So definitely you can see a reduction in annualized relapse rate as compared to placebo. Teriflunomide 14 milligram reduced the risk of sustained accumulation of disability compared to placebo, was fairly significant, was only 0.044. However, that was the dose that's approved by the FDA. So almost every patient gets the 14 milligram. Some patient that's more sensitive, sometimes you can start with the 7 milligram and then go up the level. Most common adverse events that were seen, hair thinning, LFTs increases and headaches, no other major. I've seen in some of my patients neuropathy, especially of the feet. But other than that, most of the time, the medication is well tolerated. This is the data of the TEMSO trial. So you can see it was compared to placebo. Definitely a reduction in relapse rate by about 30%. So it's not as high as the other medication, but pretty good data in large studies. And this is the total lesion volume looking at MRI data. And you can see that the placebo arm has a higher MRI lesion, higher burden and of disease and higher total lesion volumes, which is important to see in this, that the 14 milligram was the lowest one on the MRI presentation. AE, I mentioned some of them earlier. So LFTs definitely can be teratogenic in men and women. So therefore, it has a pregnancy category X. So you want to think about that. Important to know the fact that you can wash it out from the system. So often you can also give it to women at childbearing age because you can wash out the medication from the system. And you can also do a test after to make sure that the level of teriflunomide in your blood is lower down. So you can wash it out with cholestyramine or activated charcoal. Most of the time I used in my practice cholestyramine, a little unpleasant to swallow, but people can put it in a smoothie and they can be creative. Other side effects can relate to teriflunomides or GI side effects. I spoke earlier about hypertension and polyneuropathy. Let's move on to fumarate oral therapy. So we have few of them. We have dimethyl fumarate, which is Tecfidera. We have monoamyl fumarates, that's the bifenthrin, and the oxamyl fumarate, which is Vumerity. So 2 out of the 3 are manufactured by Biogen. So you can see the indications: relapsing form of MS, all of them same indications. And similar mechanism of action. They have an antioxidant property and effect and modulating the immune system using an anti-inflammatory impact. And the safety is fairly similar. Some of them have less flushing, less GI issues, although you may have flushing with all medication and some GI symptoms. Just talking about the MOM, more specifically in relation to the dimethyl fumarate, that's Tecfidera. As you can see, it has a robust anti-inflammatory effect. It decreases IL-4, IL-2, TNF alpha, tumor necrosis factor alpha, which all can produce inflammatory effect. It does induces transformation of Th1 into Th2, creating a shift and promoting more an anti-inflammatory effect, does have some apoptosis of active lymphocytes and downregulate adhesion molecular molecules, which will probably reduce some trafficking and the antioxidant effect through the NRF pathway. So this is some study with Tecfidera with dimethyl fumarate, and this is the DEFINE study, also a very large study. 1,200 patients were randomized either to dimethyl fumarate twice or 3 times a day or placebo, so 3 arms. So you can see that it's a designs that repeat itself. You have 2 different dosages of each medication, and then you have the placebo arm, and you can see looking at the relapse rates, the placebo has the higher on the graph. You can see it on the graph here. So the proportion of patients who had a relapse was 27% with DMT twice, 26% with DMT 3 times, compared with 46% placebo. So this is a p-value of less than 0.001. So therefore, the annualized relapse rate was reduced by 53% with DMT twice, 48 with 3 times a day. So very similar, and it definitely chose the twice daily. If you did it 3 times, will be so much adherence issues. Anyhow, adverse event, I mentioned the flushing, the GI event, and of course the lymphopenia that may occur and elevated liver profile. There are a few cases of PML in dimethyl fumarate, Tecfidera, and I spoke already about the other side effects. So those are the medium efficacy disease-modifying therapy that we discussed. We discussed the teriflunomide, Obagio. We talked about all the S1P modulator, and about lastly about the fumarates. So let's talk about high-efficacy medication in MS. Monoclonal antibodies, the first one that was developed and approved by the FDA is natalizumab, which is Tysabri, which inhibits and blocks the alpha-4 subunit of the alpha-4 beta-1 and beta-7 integrin, which is blocking an adhesion molecule that's responsible for trafficking of activated cells into the CNS. So by blocking the adhesion molecule, you reduce the activation of lymphocytes lymphocytes and reduce the trafficking into the central nervous system of these active lymphocytes, which is important in MS because you minimize the impact in the central nervous system. It definitely decreases relapses, disability, and MRI activity, and has improvement on measure of mental and physical quality of life. It's given intravenously every 4 weeks. However, there is some data from recent research that every 6 is as well effective. As you can see, natalizumab was compared in the AFFIRM study against placebo, and you can see that placebo has much higher relapse rate. The Tysabri natalizumab reduced relapses by 68%, which is really a high effect, high impact. And also natalizumab significantly reduced risk of sustained disability by 42%, which is nice, over 2 years with a very good p-value. So it's important to look at these two components of disability and relapse rates. There's some hypersensitivity and some AE, which I will have here in the next slide. So you can see infusion reaction, potentially fatal complication, which is progressive multifocal leukoencephalopathy, PML, which is a progressive. And I'll have slides, I think, the next one about PML. So important to think about it. And now we can stratify by checking and measuring JC antibody, JCV. Elevation in liver enzyme was seen, rare cases of malignant melanoma was reported, and of course we have the touch risk management program. This is the information that I mentioned about PML. So it is a progressive demyelinating disease of the CNS. It's an infection of oligodendrocyte by the JC virus. It's a human polyoma virus. It may be fatal within 6 months of diagnosis. It reactivates in setting of profound immunosuppressive when you take medication for MS. And it primarily, of course, affects patients with immunocompromised immune system, either patients with HIV, status quo transplant that are on multiple medication, and some hematological malignancy. This is a picture to show the difference between PML and MS. This is a slide courtesy of Ivy Maloney. So you can see that the PML show a fulminant area of disease in the central nervous system as opposed to MS. Although I might tell you that it's challenging sometimes to distinguish because some patients will have some large lesion and high burden of disease that it's challenging to distinguish between MS and PML. Next is the anti-CD20 monoclonal antibody. Here we talk about a few FDA medication, ocrelizumab, which is Ocrevus, ofatumumab, Kesimpta, rituximab, although it's not FDA approved, and oblituximab, which is not FDA approved, probably will be approved by the end of 2022. Mechanism of action, so it binds, the medication binds to a specific selective area in the immune system to CD20 found on the surface of B cells, and therefore it causes cell lysis, and it will cause a reduction in the B cells memory cells. Excuse me. It's infused every 6 months. The first 2 dosages give it in a more close every 2 weeks, but that's only the first 2 dosages, and then it's extended to every 6 months. You always want to make sure of every medication that's high-efficacy or any medication for MS, you want to check for vaccine, do vaccine before you start the medication, do all kind of housekeeping before you start the medication, do all blood tests. It's really important to focus on preventative medicine and not nursing and not start the medications. And I think we all clinicians do the same. So definitely lead to depletion of B cells, and it's approved since March of 2017. There is ocrelizumab approved for relapsing remitting MS, or relapsing forms, and for primary progressive MS. This is the only medication that's approved for PPMS. And as I mentioned, the dosing, you can look at it. I'm sure you're familiar with the dosing. So looking at disease, disability, and also look at other endpoints such as the 25-foot time walk and T2 lesion volumes and all brain volumes. So they look at brain volume. So you can see in primary progressive, there is a modest reduction. It's not as robust and high efficacious drug as you can see in relapsing remitting MS or relapsing form of MS. So you can see 24% reduction in confirmed disability progression, 25% in 24 weeks of confirmed disability progression, and 29 in after the 25-foot walk. So all these measures of disability and functionality were pretty modest. You can see mid 20% or higher 20%. And then there was a reduction in T2 volumes, decrease in brain volume loss. And what's really was robust in the primary progressive patients was a reduction in 92% reduction of new or enlarging T2 lesion. So this is the RMS trial, the OPERA 1 and 2, and you can see pretty large study, an upper 800 randomized to either ocrelizumab and then repeat versus interferon beta 1A versus Rebif. So you can see comparing ocrelizumab to Rebif head-to-head study, which is very important in clinical practice. The annual relapse rate was 46% and 47% in the other dosing in the two study, OPERA 1, sorry, and OPERA 2. But you can see as compared to Rebif, which is a very strong interferon medication, you have reduction in annual relapse rate, also in confirmed disability, not as robust, and then very robust reduction in gadolinium enhancing lesions in those patients on ocrelizumab in OPERA 1 and OPERA 2, impressive. And no evidence of disease activity. I meant to say NIDA. Those patients, so 64% on OPERA 1, 89% on OPERA 2, compared to interferon beta 1. So impressive data against interferon. Safety, there's some infusion reaction. There is increased risk for sudden infection, more upper respiratory. I have not seen that many opportunistic infection at all in my practice. Definitely you want to hold medication or not start in patients that have active infection. And thinking, as I mentioned, about vaccinations before starting the medication, especially mostly live attenuated vaccines are not recommended in MS, but again, it's always risk versus benefits, important to look at that. And malignancy, there was some increased risk of malignancy, breast cancer, so there was signal for breast cancer among the patient on the ocrelizumab arm, none were in the interferon arm, which is important to think about and report if it occurs. Next medication is alemtuzumab. It's a monoclonal antibody humanized one directed at CD52. So it has a cytolytic effects, reduces circulating T cell, B cell, monocyte, and natural killer cells. It was approved by the FDA for indication of MS, and it's also used in oncology as well. This is one of the study of alemtuzumab. As you can see, about 300 patients that were naive with relapsing were randomized to 1, 1, and 1. And you can see, again, you have two different dosages of alemtuzumab versus interferon beta 1A, which is Rebif. And of course, alemtuzumab is given IV, and you can look at the dosing. It's something that you can have. You should have a protocol if you have many patients on alemtuzumab. This is one of the study. We were, let me backtrack here. So when you think about annualized relapse rate, you can see purple is interferon beta 1A, which is Rebif, and the green is the alemtuzumab, and you can see a remarkable reduction in annualized relapse rates between each arms of the data here, years 0 to 3, 0 to 4, and 4 years. So all of them show a remarkable reduction in relapse rate, in annualized relapse rates as compared to interferon beta-1A, which is Rebif sub-Q, and then change from baseline to here, you can see a remarkable reduction in the alemtuzumab, which couldn't be reproduced with the other study, which is a shame, but this is a remarkable reduction going all the way to the other side of the equation, so of the axis, and showing a remarkable improvement in disability. So here you can see relapses. Again, the black is the sub-Q interferon, which is Rebif, and you can see a reduction in 74% of relapses. Sustained disability, a reduction 71%, which is an amazing data. However, there are multiple safety concerns with the use of alemtuzumab. One of them is immune thrombocytopenia purpura, which is an autoimmune disease associated with antiplatelet antibodies. And then you have platelets depletion, which definitely can have some harmful impact on patients with clotting time and causing rashes and easy bruising or hemorrhages, and especially patients that are older and have high risk for fall in those with MS. Important to think about that. Early warning signs, as you can see for ITP, is rash, petechia, ecchymosis, or mucosal bleeding. So this usually appears before serious bleeding develops. So important, especially in MS, because most of our patients that have some weakness, a sensory issue, or sensory ataxia may be at a very high risk for fall. And then if they develop ITP or thrombocytopenia, they may have some harmful outcomes. Also, another AEs that may occur with alemtuzumab is thyroid adverse event, thyroid issues majorly. So you can see some patients develop it in the control, which is comparator, the interferon beta-1A, which actually is not a control group. But however, the alemtuzumab 28 was the 12 milligrams a day, and the other one as well, 21, and both the number of patients was 108 in each one. So high risk for thyroid disease in those on alemtuzumab. Infection also increased risk, as you can see. In those patients on alemtuzumab, although also the group of Rebif had some infection AE, and very mildly the alemtuzumab had more serious AEs, adverse effects. Cladribine. Mechanism of action of cladribine, which is MAVEN-clad. It's a selective reduction of lymphocytes, greater effects on CD4, but it has some effects on natural killer cell, CD8 cells, and B cells. The initial effects can be seen 4 to 6 weeks and maintained for 6 to 16 months after the oral administration of cladribine. The results, so you can see also again, they have two different dosages, 3.5 milligram or 5.25 milligram per kilogram. But you can see it's significantly lower the annualized relapse rate than in the placebo group. And you can see the group was the 3.5, had a reduction in relapse rate, as you can see, and it was highly statistical significance. The group of the placebo group had 0.33, and the other cladribine, two groups, two different dosages, 0.14 and 0.15 annualized rate. And relapse free on looking at the other side of the equation. So you can see those on cladribine, 79, almost 80%, and also the other, and placebo was 60%, which is fairly good response. Disability progression, and you can see there was some reduction in both alemtuzumab groups. MRIs showed significant reduction in the brain lesion count with highly statistical significance. So it was pretty a robust effect and reduction mainly in relapse rate and also disability data and MRI. This is the Clarity study for cladribine in RRMS, relapse and remitting multiple sclerosis. So you can see the two dosages of cladribine, the 3.5, and then the orange is 5.25 milligram per kilogram, and the placebo arm. So you can see about 58% reduction as compared to placebo in analyzed relapse rates. And the other, the 5.25 milligram per kilogram showed 55% reduction. And then looking at proportion relapse-free patient, as I just mentioned, you can see almost 80% for cladribine and 60% for the placebo, which is good results. This is the efficacy summary, as I just mentioned. The relapse-free, you recall, it was 60, 80 to 80, and then relative reduction in sustained disability progression, it was around the 30%, and a remarkable reduction in annualized relapse rates, about 55 to 60%. And then looking at MRI data, you can see enhancing lesion reducing by close to 90%, T2 lesion around the upper 70, close to 80%, and then combined unique lesions, it's about 78%. So good MRI data for cladribine. There was some safety issue, lymphocytopenia, because of some bone marrow suppression. So you can see the percentage of people that have lymphocytopenia as compared to 1.8 in the placebo group. Herpes zoster, so 8 patients and 12 in the two arms, so 20 people overall in the study of cladribine, and none had herpes zoster in the placebo group. Cancer was seen in those groups, melanoma, pancreas, and ovarian, but not one signals. And then some liver abnormality, pharyngitis, upper respiratory infections, and headaches and fever. Mitoxantrone is indicated for worsening RLMS, SPMS, and progressive relapsing, which we do not use that category of phenotype anymore, but in the time when this was approved in 2001, it was one of the phenotype of MS. We're not using anymore mitoxantrone in November. Maybe some clinicians still use it, however, due to cardiotoxicity and malignancy, it's not really used. And also there is a cap, a lifetime dose that you can take, but because of those side effects, and especially today that we have so many medication for MS, these are not usually used, although it has a specific indication for these forms that we don't have enough medications, SPMS. But we can today think that mitoxantrone had the same indication for active MS, which is important. Okay, so it was a lot of information. I know it's such a mouthful. I think we have so many, and it's exciting in one sense, but you need to be knowledgeable about the mechanism of action, the efficacy data, because I think nurses and physicians, but mainly nurses and APPs, do a lot of discussion with patients and involve them in shared decision-making and do the explanation and teaching. So symptomatic care, so of course we have multiple symptoms in MS. We have primary symptoms, secondary and tertiary, and in my symptoms articles, I also talk about another level of symptoms which you look. It's more about the rehabilitation and the recovery, but it's important to think about all these signs and symptoms that are affected by MS. As I mentioned earlier, MS is a central nervous disease which affects all systems. So you could see it is here in this illustration. By the way, all my photos are either paid to Shutterstock, I have membership there, or either are taken from PowerPoint. So all of them have copyright permissions. I actually put something on the bottom, but I don't see it in the slides. So anyhow, this is really important, just so you can see that it affects everything in the central nervous system. I think this illustration really is almost worth more than 1,000 words. It really showed the impact of MS on all our system. And also, if you think about the care and how we manage symptoms, we do a lot of non-pharmacologic. That should be your prime go-to treatments, non-pharmacologic. See if you can send to physical therapy, occupational therapy, exercise, swimming. Try to think about any non-pharmacological management for fatigue or bowel and bladder. Perhaps you can change the diet or mobility, walking or exercise. So every symptoms that you can talk about can be managed non-pharmacological. And especially when patients are growing old, it's important not to enhance polypharmacy. And then, of course, we have the pharmacological strategy. Not a lot of study that was done in patients with MS. So we don't have a lot of evidence, but we try to base our practice on evidence. So there are some medications that had some recent study associated with fatigue, with rehabilitation component and such. So definitely, I always refer my patient to PT, OT, speech as needed. Complementary modalities, it doesn't have to do massage once in a while, and make sure you manage if you have pain and thinking about wellness approaches. I think the whole symptom management can take a whole hour, so I couldn't really broaden it. Maybe in the future we will do another talk about symptomatic care. So shared decision-making is an important principle of care because you want patient to be involved in the care. You want them to engage in the care and the discussion about the different medication for their MS, the DMT, along with symptomatic care. So important to consider patient preferences, patient lifestyles. Do they want high efficacy, high risk medication, or they want something more conservative and more safe? It's always important to discuss with patients and know what's their plan for the future. Do they want to get pregnant? Do they want children? When is that plan going to take into effect? And that is the discussion between patients and MS experts. Team approach, I can't emphasize enough team approach. You can't do everything by yourself, so you need to involve the whole team. Most of the time, the nurse or the APP almost do some case management and coordination of the care, but others are involved as well, social worker. It's important to include every members of the team. So in summary, MS affects about 1 million people in the US, 3 million people worldwide. Mostly Caucasians are affected by the disease, but we can see some changes in ethnicity. Important to think about other ethnic background, other races, and how can we manage their disease effectively. Some African American are at higher risk for progression and higher disability. So important to include this and think about your early diagnosis and early treatment for these patients that are high risk for accumulation of disability and an impact in their life. You have to do a lot of workup, history, assessment, neurological exam. Make sure you think about all the disease-modifying treatments. Make sure to guide patient. Your responsibility as an MS expert is to guide the patient towards the right management. However, sometimes it has to be discussed and have a whole discussion. As I mentioned, shared decision-making. You guide the patient. You are the expert, not the patient. And you need to discuss the pros and the cons and hopefully come to an agreement and make decision on one treatment that's related to their disease. Adherence is definitely paramount. If you don't take it, then you don't have any impact. Multidisciplinary care, as I just mentioned, optimize the care and the outcomes. There are two cases that I chose to do. So one case study include a 26-year-old newly married female presented at your MS center or your clinic 2 weeks ago after being diagnosed with optic neuritis by her ophthalmologist. So great ophthalmology diagnosed her with optic neuritis and told her to go to the MS center, which is important. I had many patients that saw an ophthalmologist first and then came to see me for a follow-up. She had a brain MRI, as you can see, with and without contrast, gadolinium revealed optic nerve enhancement on the left side, OS, and 3 other T2 hyperintensity located perpendicular to the ventricle. So that's what we call very typical with MS, the periventricular area or the dorsal fingers that you can see on a sagittal flare or T2 flare. So this is important to think about the MRI presentation and in a female with optic neuritis, which most commonly is the first episode that happened in multiple sclerosis. You treated her because of the visual loss and she had optic neuritis with IV methylprednisolone, 1 gram daily for 5 days. And that's the regimens that I used for many, many years at Mount Sinai Hospital. She returned to your center to discuss after the acute relapse managers. We talked, remember, you want to manage the acute attack, the acute relapse. We have 10,000 names for the same thing, but it's the same thing. You have an acute event, so acute episode. So she comes back, she was treated, she recovered. Now she comes back to talk about the maintenance therapy. What are you going to go now? She has a past medical history of migraines and depression. So, and she is on antidepressant since she was a teenager. So otherwise, she's healthy. So again, most of our patients, when they come in, especially young women, initially, they have no other comorbidity and usually come in with either optic neuritis or myelitis. And she and her husband would like to start a family with the next couple of years. So you have some time, but you need to think about pregnancy planning here, as I mentioned earlier. She doesn't use any hormonal contraception because it always increased the frequency and severity of her migraines, which is very commonly happen in women. She smokes about half pack of cigarette per day, but is willing to consider quitting because she's thinking about pregnancy. She enjoys exercise, but has found it increasingly difficult. She feels weak, fatigued after 30 minutes. So she's a bit concerned about it because she wants to maintain her weight. She works full-time as a teacher, and her husband came with her to the follow-up visit with you. So again, there's lots of component here, lots of education that you need, but you need to think about a disease-modifying therapy for her. She came in with optic neuritis, recovered after IV Solumedrol or methylprednisolone, has some history of depression and migraine. So you need to think about something, and is going to plan for pregnancy in about 2 years from now. So you have to think and have your mind about clinically isolated syndrome, what medication will proven to be, although every medication that's probably approved for RRMS is also applicable for CIS, clinically isolated syndrome. And what information you talk to her about pregnancy planning, that you need to get off medication, stop smoking, definitely something that needs to be considered, as smoking shown in MS to be associated with progression of disease, and also about the exercise. You may feel sometimes tired, but then you get energy. So it's important to put it in perspective, have a wellness discussion, but then think about a DMT. So is this patient is willing to take an oral medication versus an IV? So some questions that will come to mind. I probably would not use any of the S1P because she's going to plan pregnancy in 2 years. I probably would either use one of the other orals or either intravenous drug. Probably not an intravenous at this point. I probably will ask her for an oral. I can introduce as well the injectable, maybe glatiramer, which is a safe and drug in category B, but it's dependent on her motivation and how frightened she is from injectable. But I probably use one of the oral, except for, and not S1P. Case number 2, ND, is a 23-year-old woman who was diagnosed with MS at age 15. She has had very active disease, more than 1 relapse a year, while she was on the injectable, on the low-efficacy medication. And most recent brain MRI show extensive confluent periventricular white matter lesion and mild enhancement in atrophy. So that's a pretty advanced disease, active disease. She's a young female, as you can see, has a 8-year-old months-old baby, and she resumed her low-efficacy therapy immediately postpartum, and already had 2 relapses in 6 months with incomplete recovery. So as you can see, she has some disability. She has some foot drop. She uses a walker for mobility. So really very progressive disease, multiple relapses, increased risk for falls, bladder and bowel issues. So a lot of disability, a lot of symptoms. we must do something. And then the APP, of course, recommended changing her treatment to a high-efficacy drug. And she discussed this option with her, initiating either natalizumab or ocrelizumab. She was concerned about the risk of PML and potential infection, particularly during the COVID pandemic. So I think here also you need to consider the severity of the disease of MS. Sometimes patients don't think about their disease and what progression it caused them. And this is a young female. And the other side is the medication efficacy and safety. And I think an intravenous medication is something that I would choose for her at this point. But it has to be a discussion and shared decision making and such. It's not sometimes an easy discussion. Patient, of course, wants the most efficacious drug and the most safe drug, but we don't have something like that. So I think it's important to have that discussion with patients, with her partners, and have a whole open discussions about that. So as I mentioned, my email address is abc241@nyu.edu. If you'd like to email me, if you have any questions or any ideas. I would like to mention I'm not giving you any clinical advice to how to treat your patient. This is general educational discussions and teaching points, but it is not associated with any one of your clinical patients. So make sure that you're cautious, because individual patients are maybe changed from the cases I mentioned or from the whole discussion about MS here. Okay, so again, thank you so much for joining me to this discussion about MS. And in the future, we'll include MRI lecture and also perhaps some symptoms management lecture more in depth. So again, thank you so much and looking forward to your questions. Bye-bye.